السلام عليكم ورحمة الله وبركاته. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody, and welcome to the fourth session of the Glaucoma series in Sinjab Academy Glaucoma Club. And Today, our great international guest is Professor Tarek Shaarawy. Actually, this lecture was supposed to be on last Saturday, but because he was in Cairo and there was a conflict in time because of Ramadan, the Holy Ramadan, he wanted to postpone it to today. Now, he was planning to fly back to Geneva yesterday, but his flight was canceled. So he sent to me a recording of his lecture, and I'm going now to start it. And he will join us within 15 minutes because he is on the way in Cairo to the airport, and he will be with us within 15 to 20 minutes for the discussion, live discussion. So, of course, Professor Tarek Shaarawy is very well known, and no need to give any introduction about him. All of you know him very well from the previous series, and I really appreciate his great efforts in constructing the 2022 Glaucoma series and inviting a lot of international speakers because of his great friendship relationships. So, let's start now. I'm going to broadcast it.
Good afternoon. We're Ramadan Kareem. I've been asked by my very dear and distinguished and respected friend, brother, and colleague, Dr. Mazen Sinjab, to speak about to penetrate or not to penetrate in glaucoma surgery. I'm speaking to you. As you have guessed, I'm speaking to you from Cairo. On my way back to Geneva, where tomorrow we're going to host the 11th International Congress on Glaucoma Surgery. So this lecture is about the art and science of glaucoma surgery, and specifically if non-penetrating procedures are an equal or a valid option to penetrating the eye in multiple procedures where we try to filter the aqueous from the antechamber into the subconjunctival space. I've been in this business for a long time. Started with trabeculectomies and deep sclerectomies. After many years and many devices and a lot of white hair and much less hair, I'm doing a lot of minimally invasive procedures as well. And I would like to try to summarize where does non-penetration and penetration reside in these new options. So trabeculectomy have been always and still is the gold standard for glaucoma surgery. I've been very proud to say before that I have been taught trabeculectomy by Professor Peter Watson long time ago, back in 1993. And at that time, trabeculectomy was really the option and almost the only option, with very few cases going into tubes or valves. But nowadays we have more than 34 procedures that we can choose from. And those many procedures are either CE marked or FDA approval. So you can see here the trabeculectomy lies in the subconjunctival filtration bracket, an ab externo method for subconjunctival filtration. On the same column, you have also non-penetrating glaucoma surgery, and you have micro shunts or pressor flow, and all that is ab externo. Both ab interno and ab externo, you can address subconjunctival filtration using the Zen implant. So we are really more or less discussing today this part of the glaucoma surgery tree. First thing to remember when you are trying to choose what to do is that glaucoma surgeons are in fact conjunctiva surgeons. So it is very important to test your conjunctiva prior to operating your patients to be able to see if it is healthy or not. Another trick that you can do is hydrodissection intraoperatively, because as soon as you dissect with a balanced salt solution or with subconjunctival anesthetic agents, you will immediately understand and appreciate how good or
Okay. The sound and video were clear to everyone? Okay, so shall we start from the beginning? The video is 16 minutes only, so we can start it from the beginning if somebody has missed something, or we can continue from where we stopped. Okay, so let's continue. That's great.
bad is your conjunctiva. This is very different from something like this. You see here a big area of conjunctiva, limbal, paralimbal that is already scarred. So here you know what you're dealing with in terms of your conjunctiva. Another tip that helps me a lot when I'm operating my patients is really good immobilization of the globe and the ability to retract well with a good speculum. This is a speculum that I designed many years ago, and you can see that I'm using 8.0 Vicron to take a tangential corneal suture, drag or pull the globe downwards, and this gives me a quite a decent area on which I can dissect, as you can see here. Non-penetration is a very interesting option because we are not supposed to open the antechamber, and as you can see, we are opening Schlemm's canal and addressing the inner wall of Schlemm's canal and the juxtacanalicular trabeculum, where you have the maximal obstruction to outflow. So again, surgical steps would be opening or creating a scleral flap. After that, creating a deeper flap to open Schlemm's canal, and from there, peeling the inner wall of Schlemm's canal together with the juxtacanalicular trabeculum, and leaving what we call the trabecular descendants membrane through which the aqueous can percolate. When you are doing the deep flap, and I'm going to concentrate on that, you have to make sure that your dissection is really deep. And to know how deep you are, you have to first of all find the choroid. So you can see here we are working only in the angle of dissection and working with a number 11 blade, trying to identify the choroid. Once we see the choroid, we can start dissecting a few millimeters above it. So here you can see the choroid is right there, this black area, and the number 11 blade is dissecting a few microns above it. Once you do that, you know that you will be able to continue your dissection till you open Schlemm's canal. Here is the superficial flap, the deeper flap, and we are advancing our dissection, as you can see. And you have to appreciate the superficial or the surface of the sclera that is quite undissected. And here's after the first flap, and here's under the second flap, where the area looks more grayish or more blackish as you advance towards the Schlemm's canal. You can see nearer to the Schlemm's canal, the fibers of the sclera start to become more organized. So opening, so this gives you the sign that you are very close to Schlemm's canal, and then A step forward is easy enough to open Schlemm's canal, and putting some pressure on the sclera will help you, as you can see, to continue your dissection in detaching the decimates from the stroma. If the decimates and the stroma do not detach easily, you can always try to do dissection, as you can see here, blunt dissection with any decent spatula. And from there on, you can increase the window width by using a number 11 blade. You can see that from snipping up and outwards. And as I always say, the number 11 blade is your best friend here, because the blunt area is resting on the decimates membrane, preventing any perforation, while the sharp area helps you to cut up and outwards to increase the width of the window. After that, with a Mermu forceps or a decent capsular access forceps that is not too pointed, you can catch the inner wall of Schlemm's canal and peel it out. And what remains is an intact trabeculodesmites membrane through which the aqueous is coming out, as you can see. You can always augment the effect of surgery in difficult cases with mitomycin. I'm using 0.28 milligram per milliliter up to 3 minutes for regular cases, and 0.5 milligram per milliliter for cases that are refractory or at high risk of scarring. I also inject viscoelastic material through the Schlemm's canal, trying to dilate Schlemm's canal and opening it. Do that on both sides, as you can see here. And finally, I sometimes also use a reticulated hyaluronic acid above and below the scleral flap to reduce the chances of scarring. Here's a case where we could not open Schlemm's canal. We dissected too superficial, as you can see. We did not identify the choroid here, so we actually opened we went into the stroma without being in the right depth, without opening Schlemm's canal. Those are cases where you can also attempt to do a third flap, as you can see here. So I'm using again the number 11 blade, creating a third flap, and slowly, as you can see, dissecting again deeper. Maybe this is probably something like 20 microns. And we are dissecting, opening Schlemm's canal here. So this is Schlemm's canal. It's quite open now. And we continue our dissection to remove the third flap. Thankfully, this is something that doesn't happen a lot. And you can always see some bleeding happening from the two cut ends of Schlemm's canal, telling you that you are in the right place, as you can see here. I use collagen implants or multiple types of implants, and sometimes we put it again in the suprachoroidal space, not in the intrascleral space. You can see here that with an ultrasonic microscopy, we can see the sclera open here with the implant in the suprachoroidal space. And we have published on comparing deep sclerectomy with suprachoroidal implants versus intrascleral implants, and we could find a significant reduction in intraocular pressure once you put the implant in the suprachoroidal space. The way I close my conjunctiva is relatively simple, an 8-0 round needle. I use Castrofuego forceps that is very benign on the conjunctiva. And I continue my suturing continuously to close the 8-0 in itself at the end, as you can see, making sure that there's no leak on the limbal region. If pressure goes up after 2 months or more after deep sclerectomy, there's always the possibility to do a goniopuncture. You can see here. This is a video that is actually courtesy of my good friend, Nitin Anand from the UK, and we can see very gentle goniopuncture being done. And here is a study that we published on ultrasonic biomicroscopic and anti-segment evaluation of cases prior and 15 minutes after goniopuncture and 3 months after goniopuncture. And you can compare this to that. I think it's quite clear. So should we always choose to not penetrate? Well, it is a procedure that is associated with less complications. In an experienced hands and in many published reports, it shows similar results to trabeculectomy. It is definitely associated with less incidence of cataract in patients that are phakic. And in a study that was published by Alain Bron from Dijon many years ago, he showed that there was a significantly less endothelial cell loss with deep sclerectomy versus trabeculectomy. But it is a more difficult procedure. It is not an ideal procedure for angle closure glaucomas, and it is absolutely contraindicated in neovascular glaucomas. And if you are going to put an implant, and as a procedure that is slightly longer, it is potentially more expensive than trabeculectomy. Where do we go from there? Well, you have to consider also that penetration nowadays is not just trabeculectomy. Lots of other ways of penetration, for example, the pressure flow microshunt that you can see here. It is a variation on trabeculectomy, but is very controlled, as you can see, controlled by the diameter. It is not associated with an iridectomy, which definitely has multiple advantages over doing an iridectomy, and is a procedure that gives you a filtration bleb that is far away from the limbus, which means that it potentially can survive longer. And here are our results for 2 years, published results. You can see we went from 22 to 13.8, and the number of medications went from 2.2 to 0.5 after 2 years, which is really decent results after the pressure flow microshunt. If you compare the microshunt to the trabeculectomy, indeed, trabeculectomy still offers a lower intraocular pressure, but is associated with a significantly more higher rate of complications. The good thing about the microshunt device is that you can go back and revise it. As you can see, this is an implant that is totally buried within scar tissue and with very blunt dissection with a small Vanus knife. We are able to retract the scarring away, and we are able to ensure that the implant is working well and doing a resurrection for this device. So this is one of our lectures dealing with science and art of glaucoma surgery that is organized and spearheaded and mentored by Professor Mazen Sinjab. Thank you very much for your attention, and I will be available for any questions. Thank you.
Assalamu alaikum. Dr.
Alaikum assalam, Dr. Mazen. How are you?
I'm fine, thank you. Actually, it was an amazing lecture, very concise and direct to the point, and very nice. Thank you very much, as usual.
You're always very kind. Thank you.
I think now you are in the lounge of the airport.
No, I'm halfway to the airport in a coffee shop.
Great. So we can open discussion now. If any questions. our friend Dr. Ali Sheikha as well will join us. For discussion.
السلام عليكم دكتور طارق.
السلام عليكم السلام دكتور علي. السلام عليكم دكتور علي.
وعليكم السلام.
كل سنة وحضرتك طيب.
وانت طيب ان شاء الله. كل عام تقبل الله منا ومنكم.
اللهم امين. اللهم
امين امين ان شاء الله ان شاء الله. Dr. Tarek, about the deep sclerectomy, are you find any advantage for this now from GBL? This is the isnober implant to put under the sclera or suprachoroid?
Yes, Dr. Ali, I started doing deep sclerectomy using the collagen implant, the Aquaflow, but unfortunately it has been discontinued. For that reason, I have completely changed my practice in non-prosthetic surgery using the Esnoper, either the intrascleral one or the clip. The clip is very clever because it is something that it's an implant where half of it is in the suprachoroidal space and half is in the intrascleral space. So it should give you double benefit. I have not personally conducted any randomized controlled trials on the Esnoper, but there are lots of prospective non-randomized trials that show significant or that show really good results with the Esnoper. So being the only thing that is available more or less is something that I'm using. You can also, if you have no access to the Esnoper, you can use the HeLaFlow, a reticulated hyaluronic acid that is injectable. Either the Esnoper or the HeLaFlow should improve your success rates because they are basically space occupiers. While the clip or anything suprachoroidal would also open the suprachoroidal space, and we could show in our studies that suprachoroidal filtration has a significant impact on the reduction of intraocular pressure.
But are you notice this is in the first few 2 weeks or 3 weeks, the IOP in the lower in 2 to 6 always in this range, all higher?
I don't know if you saw the paper that I published some years ago about using the first post-operative day as a prognostic landmark or a prognostic marker. If you get a pressure between 0 to 8 in the first post-operative day, this means that most potentially your pressure will be well controlled on the long run. So, and when I'm using the Esnoper, I'm getting consistently lower pressures in the first week. But to be honest, I don't think you are getting lower pressure because of using the implant or not in the first post-operative week. I think it is really related to the quality of your dissection. If you dissect correctly, and if you dissect in the right dissection depth, you absolutely have to get a pressure under 10. A first post-operative pressure of 18, for example, in deep sclerectomy means that the Schlemm's canal was not even opened, in my opinion.
Yeah, thank you. About the pressure flow on the cyst now, also the needling or not. Usually try to make needling or you make as revision?
I revise. I never needle. I never needle. Then I never needle a pressure flow, because going blindly with a needle, you can always amputate, as they say, circumcise the implant, which is something that you should really avoid. So I think a revision, clean, obvious, clear in front of your eyes is much better than actually revising blindly with a needling.
And then here, please, are you prefer this always to make a revision and after that inject mitomycin at the end of the operation, or when you open the conj on dissect, before the dissect the pressure flow, you apply mitomycin for longer time?
No, I dissect first. I clean all the scar tissue around it, and then I put sponges. I've actually put the corneal shields 2 corneal shields, each cut into half, imbibed with 0.5 milligram per milliliter. I put them under the conjunctiva for up to 3 minutes, mostly 2 minutes, I would say. And I do that at the end of the operation before I start suturing the conjunctiva. This is of course a personal preference. It has not been studied if you put the mitomycin before or after. So again, I'm giving you my 2 cents of knowledge that is not entirely based on evidence.
Yeah, thank you.
There is a question, Professor Tarek, from Anis Kaji. Salam, Dr. Tarek. What do you think about penetrating the trabeculo-descemetic membrane with the needle if we couldn't identify the Schlemm's canal very well? Because he saw some surgeons doing that. Dr. Tarek, are you with us?
Yes,
Tarek? Yeah.
Hello, can you hear me?
Yes, we
Yes,
can.
I can
Did
hear
you
you.
hear the question? Did you hear
I
the
did.
question?
First, send a lot of greetings to my friend. Yes, I first send a lot of greetings to my friend Anis, who is a very capable and clever surgeon. Anis, I would not like to penetrate the trabeculodense membrane with a needle. This can lead to a rupture of the membrane and a dislocation and the prolapse of the iris, the interstitial space, which is something that is not really too much fun to see, and you might end up doing an iridectomy. So if I do not identify Schlemm's canal, there are 2 things to do. Either you open Schlemm's canal as in a trabeculectomy, so you do a sclerostomy, you open you basically transform the operation into a trabeculectomy, or you can try to do a 3rd flap, as I have shown in my video, to be able to find. But if you are not able trabeculectomy other than a simplified perforation that a prolapse of the iris into the interstitial space.
If you can repeat the last part, because your voice was interrupted. So if you cannot find what? Sorry?
Sure. If you cannot find, you have 2 options. Either you open the eye. That's option 2 is to create and dissect deeper, trying to find.
Again, the voice was interrupted. So the first option is to open. Sorry for that. So the first choice is to open what?
I'm so sorry. Yeah, the first choice is to open the eye simply and transform into a trabeculectomy. And the second option is to create a 3rd flap.
Yeah, it is clear. It is clear. Yeah. Yeah, thank you very much. Okay, great. Any questions from the audience?
Benefit from the time, Dr. Tarek, what is the best time to make the goniopuncture after deep sclerectomy?
Paracentesis, yeah. One is about routinely performing paracentesis. I do not routinely perform paracentesis, and the second is about gonio. I do.
We cannot hear you, doctor. So yeah, Dr. Ali, did you ask him about one of the questions? Do you routinely perform paracentesis and deep sclerectomy?
No, I didn't ask about the paracentesis, but he answered. He didn't do the paracentesis. But I asked about the goniopuncture. What the best time to do the goniopuncture after deep sclerectomy?
Goniopuncture, yeah, goniopuncture, Ali, you can do any time but not before 2 months after the operation. If you
This
do
is the-
early goniopuncture, you can have profound hypotony. So wait 2 months, and then you can do goniopuncture at any time, 3 months up to 10 years. But you need to wait for the first, prevent significant hypotony.
because I have seen one case for you is very fine after, I think, 3 months or 3 years. This is open the flap totally in the UBM. But here, make only for one hole or make more than one hole, larger one.
I make 5 holes, more or less 5 holes near to the cornea, away from the iris.
This is good. Yeah. Yeah. Thank you.
You're welcome.
What are the settings for goniopuncture? Luai
Yes,
is
I'm
asking.
sorry. I was saying, but maybe the net.
Not clear, Dr. Tarek. We cannot hear you. We can hear the Nargila voice instead. Dr. Tarek, are you with us?
Did you?
Hello. We cannot hear you, Dr. Tarek. Hello.
Enough, my.
We cannot hear you, Dr. Tarek.
Yes, Dr. Melton, I'm with 3.5 millijoules.
Okay.
Laser setting, and I do 3 to 5 punctures.
Mm-hmm. Okay, great. Yeah, this is the answer. How many shots? Okay, 3 to 5 punctures. Okay, perfect.
Exactly.
Thank you very much. So we still have time, maybe 10 to 15 minutes. Do you still have time, Professor Tarek?
But
Dr. Tarek?
to learn from Dr.
We cannot hear you, unfortunately.
Hello? Hello?
Yes, we cannot hear you, Doctor. Your voice is very interrupted. طيب, let me ask Dr. Ali until Dr. Tarek can find a way for better connection. Dr. Ali, can you answer this question? When to penetrate? It is better not to penetrate, of course, as Professor Tarek said in his lecture, because less complications, less cataract, too many benefits. But when we are obliged to penetrate, what do you think?
At first, this is, if you cannot do the deep sclerectomy, you should penetrate. This is one. When you your target pressure is the lower tens. When you need the IOP on the lower tens, this is the most important to do trabeculectomy. Usually, when you assess your target pressure, especially with normal tension glaucoma or very advanced glaucoma, can you go for trabeculectomy? Otherwise, deep sclerectomy is a very good solution to do.
So again, for normal tension glaucoma, it's better to penetrate.
If you go for a surgery, it's better to go with the trabeculectomy. Otherwise, because deep sclerectomy you cannot take as a lower target pressure. The best, the lower target pressure is with the trabeculectomy. Also, this is if you have any, for example, this is yesterday I have one case, a young patient. I prefer always with young patient to go for deep sclerectomy, but this young patient is steroid responsive. One case and has very high allergy, vernal keratoconjunctivitis. In this case, I go for a trabeculectomy. I prefer trabeculectomy, but I go for trabeculectomy. I am sure this is with the trabeculectomy. I go for lower target patient with tunnel vision. Go for lower target pressure. If I use steroid for longer time, I am more in the safe side to decrease the pressure. For each cases, can you adapt it, depend on your patient, on your target pressure, on the case also.
Perfect. Now, if the eye, you expect that the eye has very thin sclera, for example, in axial myopia. So do you still do a deep sclerectomy or better to do trabeculectomy? Because I think if you go for the deep technique, which is multi-layers, you may not have sufficient thickness of the sclera. What do you think?
Already, this is in this case you have two problems. If you go for trabeculectomy, you have also the higher risk for hypotony. A myopic patient or a young patient have more risk for hypotony. And if you go for deep sclerectomy, you have thin sclera. This is depend on your sclera when you start with the flap. That's with this patient, when you say this is thin sclera, usually is at the limbus where the area for the operation usually is not so much too thin as you expected posteriorly. In this case, can you go for deep sclerectomy? When you start with the flap, you know what is this, your sclera. As shown in many video by Dr. Tarek, when you start the first, you see how much is the deep for your sclera. And you can decide how much the sclera here, and can you plan your surgery depend on the location, on the thickening for the sclera. If you find the sclera thickness is good, and this patient is better to go for deep sclerectomy to avoid at least the hypotony, especially in young patient and myopic patient.
Very good. Now, in case of cataract and glaucoma, exfoliative glaucoma, let's say that the eye pressure is about 30 without medications. With the maximum medications, it is almost 18. And the patient has cataract. Let's say that the cataract is not that mature. It is about, let's say the vision is 0.6 decimal, and the cataract is nuclear plus 1 to 2 with some cortical. So in such a situation, do you go for glaucoma surgery first, cataract surgery first, combined surgery, and if combined, which type of surgery do you do?
First, if you've had any degree of cataract, you cannot open the eye without a glaucoma surgery. If you go for the first choice only for glaucoma surgery without cataract, in short time you need the cataract surgery. If you need any cataract surgery in short time after glaucoma surgery, you have very high risk for at least for trabeculectomy. This is documented in one study. If you did the cataract surgery, especially in the first 6 months or the first 1 year, the more higher risk for trabeculectomy failure. For that advice, if you expected you need the cataract surgery in the first few months, it's better to do the combined surgery. It's not to do the cataract surgery later. I think this is one study is hazard ratios that's decreased to 1.1 after 1 year. After 6 months is 1.7. And the first 6 months is more than 3 times. For that, it's better to go for combined surgery. If you decided to do glaucoma surgery, I need cataract surgery in the first few months after glaucoma surgery. If the patient in the early to moderate, I can go only for cataract surgery. If the patient is more advanced, I prefer to go for a combined surgery. many surgeons find that this is the combined surgery is with also more higher risk than trabeculectomy alone. For that, here depend on the case, depend on the stage of the glaucoma, depend on the response for the glaucoma medication. Because usually, if you give the example for pseudo exfoliation, usually pseudo exfoliation, you find the pressure sometimes accept response very well to anti-glaucoma medication, and after that, in short time, is very high on not responsive, and also very quickly a visual field defect. For that, should be careful is not to do surgery in these cases. If you find that there is fluctuation in the IOP or there is very rapid visual field defect or deterioration, I prefer to go for the glaucoma surgery, either a glaucoma with cataract, in this case, because the patient has first nucleus sclerosis +2, because this case is, if you open the eye, you have very high risk, more than 30% to need surgery in the first few months. For that, I prefer in this case to go for combined surgery if there's more advanced glaucoma.
Okay, great. Thank you very much. I think by this we came to the end of this session because Dr. Tarek messaged me.
It's not connected?
No, unable to connect because he is not in a proper place for connection, and he is on the way to the airport anyhow.
Okay.
So thank you, Dr. Ali, for joining us, and always we get benefit from your experience. And thanks to the audience for being with us, and have a good night for everybody. Assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu alaikum wa rahmatullahi wa barakatuh.